Bismillahirrahmanirrahim. Assalamu alaikum everyone and welcome back to OBGB Sadia Dreams. Today we are discussing one of the most important and honestly one of the most debated topic in modern obstetrics, vaginal birth after cesarean, commonly known as VBAC. Let me begin with a simple clinical scenario. A woman walks into your antenatal clinic and she had one cesarean section 3 years ago because her baby was breech. Now she's pregnant again. The first question she asks is, Doctor, do I have to undergo another cesarean or can I deliver normally this time? So as future obstetrician, this is the question you will answer hundreds, if not thousands of time during your career. And your answer should never be based on myths, self-fears, or personal preference. It should be evidence-based on careful patient selection and informed counseling. So in this lecture, we'll answer every important question about VBAC. Who is the ideal candidate? Who should never be offered VBAC? How do we counsel patients? Can labor be induced? What are the warning signs of uterine rupture? And then finally, when should we stop the trial of labor and proceed to an emergency cesarean section? We'll also discuss the latest recommendations from RCOG, NICE, ACUD, and other international guidelines, along with the practical points that frequently appear in exams. So by the end of this lecture, you will not only know the guidelines, you will understand the reasoning behind every clinical decision. Let's begin. Before we discuss indications, contraindications, and management, it's important to know where our recommendations come from. This lecture is based primarily on the RCOG Green Top Guideline number 45, supported by the NICE guideline and current international evidence. Instead of memorizing isolated facts, we'll understand the principles behind VBAC so that you can confidently apply them in both exam and real clinical practice. So, before we discuss who is eligible for VBAC, let's first answer a very fundamental question. Why has VBAC become such an important topic in modern obstetrics? 20 or 30 years ago, there was a famous saying, once a cesarean, always a cesarean. एक दफा operation हो गया तो हो गया. But today we know that statement is no longer true. With better surgical technique, improved fetal monitoring, careful patient selection, evidence-based practice, we now know that many women with one previous cesarean section can safely achieve a vaginal birth. And that's exactly what VBAC is all about, offering the right woman the right birth at the right time under the right circumstance. Now let's understand why this matters. First, the cesarean section rates are increasing worldwide. In many countries, including the low and middle income countries, cesarean section rates are above the WHO recommendation. So while cesarean delivery can be life-saving when medically indicated, performing unnecessary repeat cesarean exposes a woman to avoidable surgical risk. So every repeat cesarean becomes technically more difficult than the previous one. Adhesion becomes more denser. Surgery takes longer time. Blood loss may increase. The risk of bladder injury, bowel injury, more importantly, the risk of placenta previa and placenta accreta spectrum increases dramatically with each subsequent cesarean section. These conditions are among the leading cause of severe obstetric hemorrhage and emergency peripartum hysterectomy. So our goal is not to simply avoid one cesarean today. Our goal is to improve the woman's reproductive health and all her future pregnancies. On the other hand, a successful VBAC offers several important benefits. It avoids major abdominal surgery. Women usually experiences less post-operative pain, shorter hospital stay, faster recovery, early mobilization, and quicker return to normal daily activities. So future pregnancies are also associated with fewer complications related to multiple uterine scars. And from the patient's perspective, many women describe a successful VBAC as an empowering and satisfying birth experience. So, however, and this is extremely important, VBAC is not suitable for every woman. It should never be offered simply because the patient requests it. It should never be refused simply because she has one cesarean. Instead, every woman deserves individualized counseling based on the best available evidence. So during counseling, we discuss her possibility of successful VBAC, the potential maternal and fetal risk, the alternative option of elective repeat cesarean, And finally, we allow her to make an informed decision. This process is called shared decision making, and it lies at the heart of the modern obstetrics. So remember this one sentence: the goal is not a vaginal birth at any cost. The goal is a healthy mother and a healthy baby and the safest possible birth experience. Now that we have understand why VBAC matters, let's move to the next question. When should this woman be counseled and how should antenatal care be planned? One of the biggest mistake clinicians make is discussing VBAC only at 36 or 37 weeks. By that time, the woman is anxious, delivery is approaching, and there's little opportunity for thoughtful counseling. Planning for VBAC actually begins much earlier in the first trimester. Let's go through the antenatal pathway step by step. See, during the early pregnancy, ideally before 14 weeks, our first responsibility is to understand the woman's previous cesarean section. Whenever possible, review the previous operative notes. It's very important. Review the previous operative notes. Why was the cesarean performed? Was the indication recurrent or non-recurrent? What type of uterine incision was used? Was it a low transverse incision, which is generally suitable for VBAC? Or was it a classical vertical incision, where VBAC is usually contraindicated because of a significantly higher risk of uterine rupture? And at this stage, we also identify the absolute contraindications, that is previous uterine rupture or conditions that already require a planned cesarean delivery. Okay, now during the mid trimester at 14 to 28 weeks, counseling becomes much more detailed. This is not just about saying you can try for normal delivery, it's a structured discussion. We explain what is VBAC, what is an elective repeat cesarean section, what are the benefits and risk of each option, what is the individual probability of success, and we also discuss factors that increase or decrease the likelihood of successful VBAC. Most importantly, this conversation should be documented clearly in the medical records, including the woman's questions, preferences, and the final plan. So by 36 weeks of gestation, the decision should ideally be finalized. At this point, there should be no uncertainty. Either the woman plans for VBAC or she plans for an elective repeat cesarean section. A clear birth plan should be documented and communicated to the labor ward team. Good planning reduces confusion during labor and allows everyone to respond promptly if complications arise. Some women, however, require specialist review before making this decision. These women include women who may need induction of labor, those with breech presentation, those with preeclampsia or hypertensive disorder, those with fetal growth restriction, those with suspected macrosomia, those with pregnancies continuing beyond 41 weeks of gestation, or whenever there's uncertainty regarding the safest mode of delivery. This situation requires individualized assessment rather than the routine counseling. So remember this important principle: the successful VBAC begins long before labor start. Careful antenatal planning, individualized counseling, and shared decision-making are the foundation of a safe and successful VBAC journey. So now that we know when counseling should take place, the next logical question is, which women are actually suitable candidates for VBAC and who should be advised against it? Who is actually a good candidate? Remember this principle. VBAC success does not happen by chance. It starts with selecting the right patient. The better the selection, the higher the success rate and the lower the risk of complications. So let's build the profile of an ideal VBAC candidate first. The pregnancy should be a single germ pregnancy. The evidence supporting VBAC is strongest for women carrying a single fetus. Although VBAC will be considered in selected twin pregnancies, single-germ pregnancy remains the standard recommendation. Second, the fetus should be in cephalic presentation. In other words, the baby's head should be presenting. If the baby is breech or is another malpresentation, the risk increase and the management strategy changes completely. Third, the pregnancy should be at or beyond 37 weeks when the fetus has reached term and spontaneous labor is expected. Fourth, and probably the most important criteria, the woman should have one previous lower segment transverse cesarean section. This type of uterine scar has the lowest risk of uterine rupture during labor and therefore offers the best safety profile for VBAC. Now now you will notice another point on this slide. Previous vaginal birth may be present or absent. This often confuses students. A previous vaginal birth is not essential to offer VBAC. However, if a woman has delivered vaginally before, especially after a previous cesarean, her chance of successful VBAC increases significantly. So think of previous vaginal birth as a positive predictor, not a mandatory requirement. Remember that an ideal candidate is simply a woman whose chance of success is high and whose risk of uterine rupture is low. And that's exactly why careful patient selection is the foundation of safe VBAC practice. Okay. Now, if we know who can have VBAC, the next question becomes equally important. Who should never have VBAC? Contraindication. Not every woman with a previous cesarean is suitable for a trial of labor. Some conditions carry such a high risk that attempt a VBAC would be unsafe. So these are called absolute contraindications. You know, this is called absolute contraindication. The first is previous uterine rupture. It's a big no. A uterus that is ruptured once has a substantially increased risk of rupturing again during labor. For this reason, these women are generally advised to have an elective repeat cesarean section. The second absolute contraindication is a previous classical cesarean scar. Unlike the usual low transverse incision, a classical incision involves the upper muscular segment. So this portion contracts much more forcefully during labor, making scar rupture significantly more likely. Therefore, VBAC is contraindicated. And finally, any contraindication to vaginal birth automatically becomes a contraindication to VBAC. The classic example is major placenta praevia. है ना? Here the placenta completely or partially covers the internal cervical os. Even if the woman had never undergone a cesarean section, vaginal delivery would still be unsafe because of the risk of catastrophic hemorrhage. So therefore, the safest option remains the cesarean delivery. Here's an easy way to remember this. If vaginal birth itself is unsafe, then VBAC is also unsafe. That's an excellent exam sentence and an important clinical principle. Okay, but what about women who don't have a classical scar, yet their previous uterine incision was not the routine lower transfer incision? That's when they understand the type of uterine incision becomes crucial. This is one of the most commonly tested areas in exam in FCPS, MRCOG, and MS. Students often remember the skin incision. But what actually matters is the uterine incision, because of the scar that must withstand with the stress of labor. The safest incision for VBAC is low transverse incision. It heals well, lies in the lower uterine segment, carries the lowest risk of uterine rupture. However, not all uterine incisions are the same. Some require much greater caution. Let's go through them one by one. If it is inverted T, okay? So inverted T combines a transverse incision with a vertical incision, vertical and a transverse incision, okay? Because a scar extends to the upper segment, the risk of rupture is high. A J-shaped incision, it also extends beyond the usual lower segment and increases the possibility of scar weakness. A low vertical incision or DL incision, it is limited evidence, although it is lower than the classical incision. Available data suggests a higher risk than a routine transverse incision, so management should be individualized. Finally, we have significant uterine extensions. Sometimes during a difficult cesarean section, the incision accidentally extends laterally or vertically because of an impacted fetal head or obstructed labor or difficult extraction. So these extensions may weaken the uterus and increase the risk of a rupture in a future pregnancy. This is why reviewing the previous incorporated note is so important. And here's an important practical point. If you're uncertain about the type of previous uterine incision, do not assume it's low transverse. Manage the patient as highest risk until more information becomes available. So the take-home message is low transverse incision is generally suitable and this is the safest option for VBAC. And any unusual uterine incision or significant extension requires senior obstetric review and individualized decision-making. So safe VBAC is not just about encouraging vaginal birth, it's about understanding the scar before labor even it begins. So far we have discussed now it is what if a woman has never had a cesarean but she has undergone previous uterine injury? Can still she be offered a trial of labor? The answer is it depends. The key issue is not simply whether surgery was performed. The real question is whether the surgery has weakened the uterine wall. Look at some common example. First, open myomectomy. Okay. If the surgeon removed deep fibroids requiring a full thickness incision into the uterus, the integrity of uterine wall may be compromised. The risk of uterine rupture depends on several factors: the size, the number of fibroid, the location, and the surgical repair technique. Next is laparoscopic myomectomy. If the endometrial cavity was breached or if the extensive reconstruction was required, the risk may also be increased. And finally, women who have undergone major uterine reconstructive surgery, such as metroplasty or extensive septal reconstruction, requires careful assessment because these procedures may alter the strength of the uterus. Now, here is the important point. These surgeries are not automatic contraindication to VBAC, but instead every woman requires individualized counseling. Review the previous operative notes whenever possible and understand exactly what surgery was performed. Discuss both the potential benefits and risks with the woman. And whenever uncertainty exists, involve a senior obstetrician. And remember that good obstetric is really about rigid rules. It's about making the safest decision for the individual woman sitting in front of you. Okay. Another important condition that often raises question in women with a previous cesarean is placenta previa. Placenta previa is actually quite straightforward. You don't need to memorize complicated rules. Just remember one basic principle. If vaginal birth is unsafe, VBAC is also unsafe. Major placenta previa means placenta completely covering the os or partially covers the internal os. During labor, as the cervix dilates, the placenta separates prematurely. This can result in massive maternal hemorrhage, severe fetal compromise, and a true obstetric emergency. Therefore, major placenta previa is an important and absolute contraindication to vaginal birth and VBAC. Planned cesarean delivery is the safest option. Now, let's briefly look at different types. Complete and partial placenta previa classified as major placenta previa, and these require cesarean delivery. Marginal and low-lying placenta previa are different. Their management depends on the placental distance from the internal os during late pregnancy and should be assessed individually. One final clinical pearl is that women with previous cesarean section are at increased risk of developing placenta accreta spectrum in future pregnancies, and the risk increases with every additional cesarean section, which brings us back to why avoiding unnecessary repeat cesarean is so important. So, when speaking of repeat cesarean, a question students ask all the time is, can a woman with 2 cesarean sections still have VBAC? The answer may surprise you. Many clinicians automatically assume that 2 previous cesarean mean a mandatory 3rd cesarean, but current evidence tells us that's not always true. According to current guideline, carefully selected women with 2 previous lower segment transfer cesarean section may still be offered VBAC. However, this should never be a casual decision. First, detailed counseling by a senior obstetrician is essential. The woman should understand the risk of uterine rupture is slightly higher than after 1 previous cesarean. Although the absolute risk remains relatively low, she deserves clear information before making her decision. We should also discuss an expected success rate. Also, all right, am I clear? That is 60 to 75%. Depending on the individual clinical factor, approximately 60 to 75% of women can still achieve a successful VBAC. And the critical requirement is immediate theater facility available. This means an experienced obstetric team, anesthetist, OT, neonatal support, blood transfusion services should all be available without delay. Therefore, women after 2 cesareans should only be attempted in a well-equipped hospital with experienced multidisciplinary team. 2 previous cesarean do not automatically exclude VBAC, but they definitely require more careful selection, better counseling, and appropriate facilities. Am I clear so far? Even after selecting the right patient, some factors can still increase the risk of likelihood of uterine rupture. These are not absolute contraindication, but they certainly influence our counseling and clinical decision making. One of the biggest misconceptions about VBAC is believing that every patient carries the same risk. In reality, risk is dynamic. It changes according to individual maternal and pregnancy factors. Let's go through them one by one. A short interpregnancy interval, especially less than 12 months, allows less time for complete scar healing and may increase the risk of rupture. Post-term pregnancy is another consideration. Women who go beyond the due date are more likely to require induction or augmentation of labor, and both of which may increase the stress on the uterine scar. Advanced maternal age, more than 40 or older, has been associated with lower VBAC success rate and slightly increased complication. Then maternal obesity can reduce the likelihood of successful vaginal birth and increase the obstetric intervention. A lower Bishop score before labor suggests an unfavorable cervix. These women often require induction, which makes counseling even more important. Then macrosomia, particularly when the estimated fetal weight exceeds 4 kg, may reduce VBAC success and increase the risk of difficult labor. And finally, decreasing the lower uterine segment thickness on ultrasound has been investigated as a marker of scar integrity. Although ultrasound may provide useful information in selected cases, there is currently no universally accepted cutoff that should be used alone to decide whether VBAC should or should not be offered. So here is the key message. These factors are not absolute contraindications, okay, but they should be considered during counseling and decision making, and our responsibility is to recognize them, discuss them honestly with the patient, individualize our management, and ensure that labor occurs in a setting where immediate intervention is possible if required, because ultimately, successful feedback is not about eliminating every risk, it's about understanding the risk and preparing for it and managing it safely. Okay. Now, one of the most important questions in modern obstetric is, can ultrasound predict uterine rupture? More specifically, can measuring the lower uterine segment help us decide whether a woman is suitable for VBAC? The short answer is yes, but only to a certain extent. Lower uterine segment thickness is a useful tool, but it is not a perfect test. And it should never replace clinical judgment. Let's understand why. During the late third trimester, the previous cesarean scar can be assessed using either a transabdominal or transvaginal ultrasound. The sonographer measures the myometrial thickness at the thinnest point of the lower uterine segment because this is the area most likely to rupture during labor. Now let's see. Now let's interpret the finding. If the myometrial thickness is between 2.1 and 4 millimeter, the scar is generally reassuring. In other words, the likelihood of uterine rupture is low. On the other hand, if the thickness is between 0.6 to 2 millimeter, the risk of scar defect or uterine rupture becomes higher. But here is the most important message, and this is the favorite examination point. There is currently no universally accepted cutoff value, and that should be used alone to decide whether VBAC should or should not be offered. Different studies have proposed different threshold, and ultrasound techniques also vary. Therefore, lower uterine segment thickness should be viewed as one piece of the puzzle, not the entire picture. It should always be interpreted alongside the woman's previous obstetric history, the type of uterine scar, clinical risk factors, and an O preference. So remember this example that lower uterine thickness supports counseling, but should never be the sole reason to recommend or deny VBAC. Clinical judgment always comes first. So far, we have discussed eligibility, contraindication, and risk assessment. Now, let's move to perhaps the most important conversation you will have with your patient. How do we counsel her when choosing between VBAC and elective repeat cesarean section? This is where medicine becomes truly patient-centered. Our job is not to convince every woman to choose VBAC, and certainty not to recommend repeat cesarean for everyone. Our responsibility is to represent the balanced, evidence-based information so the woman can make an informed choice. Okay, now let's begin with planned VBAC. If VBAC is successful, it offers the greatest overall maternal benefit. Women usually experiences a shorter recovery time, less post-op pain, and they should avoid another major abdominal operation. Perhaps even more importantly, successful VBAC reduces the risk of further surgeries, and in future pregnancies. However, every benefit comes with its own risk. The estimated risk of rupture during planned VBAC is 0.5%, 1 in 200. Again, I'm repeating it. First of all, if VBAC is successful, she has higher benefit if successful. She has short hospital stay, fast recovery, may repeat abdominal surgery in future pregnancy. And the thing is, approximate uterine rupture risk in VBAC is 0.5%, around 1 in every 200 women. Although uncommon, it remains the most serious complication we discussed during counseling. Now let's look at the other option. Elective repeat cesarean section. An elective repeat cesarean section almost completely avoids labor-related uterine rupture because labor itself is avoided. But that's not the end of the story. Every additional cesarean increases the long-term risk of placenta previa, placenta equita spectrum, pelvic adhesions, and surgical complications like bladder or bowel injury and more complex surgery in future pregnancy. So the question is not which option is perfect, because neither option is. The real question is which option offers the best balance of benefits and risk for this particular woman. That's why counseling should always be individualized. Discuss the probability of VBAC success. Explain both immediate and future pregnancy risks. Listen carefully to our concern. Respect our values and preferences, and then make a shared decision together. That's evidence-based obstetrics at its best. Am I clear so far? Let's finish the most important message. Number one, counseling should be individualized. Number two, documentation is a good clinical practice. Document counseling in your notes for you and your good medical legal practice. Number three, whenever possible, provide a patient information leaflet and inform women is far more likely to make a confident, well-considered decision. Number four, successful VBAC is associated with lowest overall maternal morbidity and the fastest recovery. Number five, the greatest maternal morbidity is not with successful VBAC or planned repeat cesarean, occurs with the failed trial of labor requiring emergency cesarean section. That's for careful patient selection is absolute essential. Number six, the risk of uterine rupture during planned VBAC is approximately 0.5% or about 1 in 200 women. And finally, elective repeat cesarean avoids labor-related rupture, increases the risk of placenta previa, accreta, and surgical complication in future pregnancies. Okay, so now we have discussed who should be offered VBAC. Now let's answer the question every patient eventually asks, doctor, which option is actually safer for me? And the answer is, it depends on whether the VBAC is successful or not. Let's begin with planned VBAC. Approximately 72 to 75% of carefully selected women achieve a successful vaginal birth. That means almost 3 out of 4 women avoid another cesarean. A VBAC is successful, benefits are substantial. Women usually have a shorter hospital stay, faster recovery, and return to the normal daily activities. More importantly, they avoid another scar. They preserve the possibility of easier vaginal birth and future pregnancies. However, we must also discuss the most real complication, the risk of rupture. That is 0.5% or 1 in 200. That is the risk of rupture. The major advantage. Now let's compare this with elective repeat cesarean section. The labor is avoided, planned date of delivery. Therefore, labor-related joint rupture is almost completely eliminated. But it has longer recovery, high risk of praevia, accreta, adhesions, and repeat surgery risk. So now when we counsel women, we must remember that we are making decision for 2 patients, not 1. So let's look at the infant's outcome. Overall successful VBAC is associated with excellent neonatal outcome. However, because labor is involved, there remains a very small risk of serious complication if uterine rupture occurs. Studies show that the risk of antepartum stillbirth is approximately 10 per 10,000 pregnancies. The risk of hypoxic ischemic encephalopathy is around 8 per 10,000, while delivery-related neonatal death is approximately 4 per 10,000. And thankfully, these complications remain uncommon. And if we compare it with elective repeat cesarean section, because labor is avoided, elective repeat cesarean section provides greater protection against labor-related hypoxia and hypoxic ischemic encephalopathy. However, timing becomes extremely important. If an elective repeat cesarean section is performed before 39 weeks, neonatal respiratory morbidity increases significantly, 4 to 5%. Why? Because labor itself helps repair the fetal lungs by promoting the clearance of the lung fluid. When the labor is bypassed too early, babies are more likely to develop transient tachypnea of the newborn or respiratory distress syndrome. That's why elective repeat cesareans should generally be scheduled at 39 weeks or later, unless there is another medical indication for earlier delivery. So here is a take-home message. The successful VBAC offers excellent neonatal outcome, and elective repeat cesarean offers greater protection from labor-related complication, but should not be performed too early because it increases respiratory morbidity. So which option is better? The truth is there's no single correct answer for every woman. The best option depends on the individual clinical situation. We should consider VBAC when the woman is an appropriate or good candidate, or women have previous lower segment cesarean section and there are no contraindication to vaginal birth. And most importantly, she understands the benefits and risk and prefers to attempt a vaginal birth. When successful, VBAC provides the lowest maternal morbidity while avoiding another abdominal operation. On the other hand, elective repeat cesarean section should be recommended when VBAC is contraindicated. Examples include with a previous uterine rupture or classical cesarean scar or major placenta previa. Simply when after informed counseling, the woman prefers the repeat cesarean. And that's something we should never forget, that respecting a woman's informed choice is a fundamental principle of modern obstetrics. We don't make decisions for our patient, we make decisions with our patients, and therefore every consultation should include balanced discussions, shared decision making, and careful documentation. Because the goal is not to achieve more VBAC, the goal is to achieve the safest birth for every individual woman. So, if you remember only 3 things from today's lecture, these be the ones. First, successful VBAC has the lowest maternal morbidity. That's why we carefully identify women with the highest probability of success. Second, the highest maternal risk is not successful VBAC. It's a failed trial of labor ending in an emergency cesarean section. That's the situation associated with greatest maternal morbidity, which is exactly why proper counseling, patient selection, and close intrapartum fetal monitoring are so important. And finally, elective repeat cesarean section reduces labor-related uterine rupture, but every additional cesarean increases the long-term risk of placenta previa, placenta accreta, dense pelvic adhesion, and complex pelvic surgeries. And always think beyond the current pregnancy, because today's delivery influences the tomorrow's pregnancy. Okay, but let's finish with some good news. One of the most encouraging fact about VBAC is that most carefully selected women succeed. Overall, the success rate is approximately 72 to 75%. In simple terms, nearly 7 out of every 10 women will have a successful vaginal birth after cesarean. But success is not the same for everyone. The strongest predictor of a successful vaginal birth after cesarean is a previous vaginal birth. And if that previous vaginal birth was itself a successful VBAC, the success rate increases to 85 to 90%, while the risk of uterine rupture becomes even lower. This single piece of history should immediately increase your confidence that the woman is an excellent candidate. So whenever you are assessing eligibility, always ask, has she delivered vaginally before? Because that answer may be the most powerful predictor of success. And with that, now another thing, we should do the counseling. Now, if we talk about that, which factors are associated with failed VBAC? Although VBAC has a good overall success rate, certain factors increase the likelihood that VBAC will end in emergency cesarean section. One important factor is induction of labor. Women requiring induction generally have lower success rate than those entering spontaneous labor. And the predictor is no previous vaginal birth. Previous vaginal delivery is the strongest positive predictor of successful VBAC. Therefore, women without one have relatively lower success rate. Maternal obesity, like BMI more than 30. Similarly, if previous cesarean section was performed due to labor dystocia or failure to progress, the probability of another difficult labor is higher. Other factors include macrosomia and advanced maternal age, and these factors don't automatically contraindicate VBAC, but they reduce the likelihood of success. So failed VBAC often leads to emergency cesarean section, which carries higher maternal morbidity than either successful VBAC or planned elective repeat cesarean section. So planned VBAC should only occur in a unit that is fully prepared to manage the emergencies. The first equipment is immediate cesarean capability. If uterine rupture or fetal compromise occurs, cesarean delivery should be possible without delay, ideally with 24-hour theater facility. Secondly, an experienced obstetrician capable of performing emergency cesarean delivery should be immediately available. Neonatal safety is equally important. Therefore, facility for advanced neonatal resuscitation with trained personnel must also be available. During labor, the woman should receive one-to-one monitoring, allowing early recognition of complication. Remember that VBAC itself is not dangerous, but delayed recognition of complication is very dangerous. Planned VBAC should only be conducted in a suitable, staffed, and appropriately equipped maternity unit. And once the labor begins, close monitoring becomes essentially important. So every woman attempting VBAC requires continuous intrapartum surveillance. The most important recommendation is continuous electronic fetal monitoring. It is very important. Monitoring should begin from the onset of active labor and continued until delivery. Why? Because the earliest sign of uterine rupture is often an abnormal fetal heart rate pattern, not maternal pain. Because the earliest sign is abnormal fetal heart rate, so you should do one-to-one monitoring, one-to-one midwifery care. Continuous assessment allows every early detection of fetal distress or maternal deterioration, and every woman should have low large bore IV access in case rapid fluid resuscitation or emergency surgery becomes necessary. Blood investigations, including full blood count, and group and safe should be available. Maternal observations, including pulse, BP, respiratory rate, temperature, and pain assessment, should be monitored regularly. Cervical assessment should also be performed to ensure labor is progressing appropriately. So the key principle is simple: vigilant monitoring plus immediate access. 2. Emergency resources equals safer VBAC. Okay, then many people ask whether epidural analgesia is safe during VBAC. They see a common myth is that epidural analgesia should not be used during VBAC. That is incorrect. Epidural analgesia is not contraindicated in women undergoing planned VBAC. It provides effective pain relief and may improve the overall labor experience. However, we must remain vigilant. If a woman with a well-functioning epidural suddenly develops increasing pain, requiring repeated top-ups, this should raise concern. It may indicate uterine rupture or another labor complication. And other warning signs that may include are sudden severe abdominal pain, abnormal fetal heart rate, vaginal bleeding, loss of fetal station, and maternal tachycardia or hypotension. Therefore, epidural is considered safe provided that continuous fetal monitoring is done. One-to-one monitoring, IV access, and immediate cesarean capability are available. Epidural itself does not increases the risk of uterine rupture. However, worsening pain despite epidural should never be ignored. Always think of uterine rupture until proven otherwise. Now, the complication every obstetrician fears during VBAC is this: uterine rupture. Fortunately, it is uncommon, but when it occurs, it is a true obstetric emergency requiring immediate action. The most common and earliest clinical sign is, yes, please, abnormal CTG. In fact, approximately 66 to 76% of uterine rupture first present with fetal heart rate abnormalities. This is why continuous CTG monitoring is recommended throughout VBAC labor. Other clinical features include persistent severe abdominal pain, especially pain that continues between contraction or pain despite a functional epidural. The woman may also develop scar tenderness, vaginal bleeding, or signs of maternal compromise such as maternal tachycardia, hypotension, shock due to concealed hemorrhage. Loss of fetal station is another important clue. A previously engaged presenting part may suddenly become high because the fetus has partially escaped through the uterine defect. In some cases, hematuria may occur if the bladder is involved. You may also notice a change in abdominal contour or easily palpable fetal parts. Once uterine rupture occurs, fetal oxygenation rapidly deteriorates, and the mother may become hemodynamically unstable. This is a race against time. During VBAC, an abnormal CTG should always raise suspicion of uterine rupture until proven otherwise. Since uterine rupture increases with labor intervention, now let's discuss induction and augmentation of labor. A common misconception is that induction is absolutely contraindicated after cesarean section. This is not true. Induction and augmentation can be performed, but they increase the risk of uterine rupture compared with spontaneous labor. Women should therefore receive senior obstetric counseling before induction. Explain that induction increases the risk of uterine rupture by approximately 2 to 3-fold, and the likelihood of cesarean section is also increased by 1.5-fold. The discussion should include why induction is needed, which method will be used, benefits and alternatives, additional risk, emergency plans if complication occur, and careful patient selection and close intrapartum monitoring are essential. Induction is not contraindicated in VBAC, but requires careful counseling, informed consent, and careful monitoring. So if induction is required, which methods are safest? Whenever possible, mechanical methods are preferred because they have a lower risk of scar rupture than a prostaglandin. The two preferred methods are amniotomy and Foley's catheter. Amniotomy, when feasible, because no uterotonic drugs are required to simple and effective. No medication is used associated with lower risk of rupture. And Foley's catheter, which mechanically ripens the cervix without stimulating excessive uterine contraction. In selected women with an unfavorable cervix, low dose prostaglandin E2 may be considered. However, should be used cautiously at the lowest effective dose and for the shortest duration. If excessive uterine stimulation should always be avoided. High dose oxytocin augmentation significantly increases the risk of rupture. Therefore, if oxytocin is required, use a minimum effective dose with continuous fetal monitoring. And mechanical methods are preferred. Remember this, mechanical method is preferred in VBAC because they carry less risk of rupture than prostaglandin. And it is an exam question. Oxytocin is not prohibited during VBAC, but it must be used with great caution. Always begin with lowest effective dose. Okay, at doses up to 10 international unit per minute, the risk remains relatively low. But between 10 to 20 international units, the risk increases significantly. So closer monitoring is required. And about 20 milliunits are associated with a four-fold increased risk of uterine rupture. So why does this happen? This is the question. Because excessive uterine stimulation increases uterine pressure and places greater stress on the previous uterine scar. So therefore, women receiving oxytocin require continuous CTG, careful assessment of contraction and frequency and strength, regular maternal observation, constant vigilance for the signs of uterine rupture. So during VBAC, avoid the high dose of oxytocin, use a minimum effective dose. Now come the certain obstetric situation which require extra caution when considering VBAC. These include post-date pregnancy, twin pregnancy, post-date especially beyond 41 weeks. Twin pregnancy may still be considered in carefully selected women in suspected macrosomia, maternal age more than 40, or antepartum stillbirth. They require individual risk assessment, senior obstetric counseling, shared decision making, continuous electronic fetal monitoring, and immediate access to emergency cesarean section. And management should always be tailored to the individual woman after balancing the risk and benefits. If you're talking about 41 weeks, that if labor has not started by 41 weeks, VBAC is not absolutely abandoned by 41 weeks, but careful reassessment is required. Pregnancy beyond 41 weeks is associated with a slightly lower chance of successful VBAC and a high risk of rupture and other perinatal complications. Therefore, every woman should have a senior obstetric review, and reassess her likelihood of successful VBAC based on cervical favorability, fetal condition, maternal factors, and previous obstetric history. Then discuss all the available options like induction of labor if appropriate, elective repeat cesarean, and maternal preference, a woman's informed choice. So if induction is chosen, continuous fetal monitoring and immediate access to theater emergency cesarean section are essential. And remember, counseling, documentation, and shared decision making are key. Around 41 plus 3 weeks of gestation, many owners schedule a provisional elective repeat cesarean, which can still be cancelled if spontaneous labor occurs or induction becomes appropriate. Okay, now VBAC in twin. Twin pregnancy is not an absolute contraindication to VBAC, but in carefully selected women, VBAC in twin can be as safe as singleton. And reported success rate is approximately 45 to 84%, depending on the patient selection. Ideal candidates include women with one previous lower segment cesarean section with a transverse scar, no additional uterine scar, both twins cephalic, especially twin 1, and no major obstetric complication. And delivery should always occur in a well-equipped center with continuous intrapartum monitoring, senior obstetric supervision, and immediate theater facility. And the risks include emergency cesarean section and cord prolapse after delivery of the first twin, postpartum hemorrhage, and slightly increased rupture risk. But previous cesarean section with twin does not automatically mean repeat cesarean. Selected women may still be offered VBAC. Macrosomia generally refers to an estimated fetal weight of 4 kg or more. The risk factors include, as you all know, that diabetes, maternal obesity, post-date pregnancy, previous macrosomic babies, or genetic or ethnic factors. So in women attempting VBAC, suspected macrosomia reduces the likelihood of success. Larger babies increases the risk of rupture and shoulder dystocia and severe penile trauma, 3rd and 4th degree penile tear. However, ultrasound estimation of fetal weight is imperfect with an error of approximately 10 to 15%. Okay, so therefore management should never rely on estimated fetal weight alone. Individualized counseling is essential. If VBAC is chosen, labor should occur in a unit with immediate theatre facility available and continuous monitoring. Previous antepartum stillbirth does not automatically require repeat cesarean section. After appropriate counseling, these women may still undergo VBAC, and study report a VBAC success rate of approximately 87% in appropriately selected women. However, if induction augmentation becomes necessary, the risk of uterine rupture increases. So careful planning is essential. And counseling should address the woman anxiety, risk and benefits, and delivery planning, and emotional support. And labor should occur in a well-equipped center with continuous monitoring and immediate surgical backup. Maternal age is another factor that often influences counseling. Women aged more than 40 or older generally have lower VBAC success rate. So they also have higher risk of antepartum stillbirth and maternal and medical comorbidities or obstetric complication. Therefore, counseling should include discussion about the optimal timing of delivery, and age alone should not determine the mode of delivery. Instead, decisions should be individualized after balancing maternal risk, fetal well-being, and the woman's preference. Shared decision-making remains central. So maternal age more than 40 years require careful counseling, not automatic elective repeat cesarean. Okay. Now preterm VBAC. See, evidence show that preterm VBAC is a reasonable option in appropriately selected women. The success rate is approximately 73%, similar to term VBAC. Interestingly, the risk of uterine rupture is lower in preterm VBAC than a term because uterine contractions generate less stress on the scar. And perinatal outcomes are generally comparable to preterm elective repeat cesarean section. As always, success depends on careful patient selection, good and continuous CTG monitoring, availability of emergency cesarean facilities, and management should be individualized. And according to gestational age and maternal fetal condition. VBAC success rate 73%, 73%, uterine rupture is lower, higher, term VBAC pay, and outcome similar to preterm elective repeat cesarean. We'll finish with a few important audit points that current research focuses on improving prediction of VBAC success using better scoring system, ultrasound assessment, and lower uterine segment scar thickness, and safer induction methods. From an audit perspective, important standards include documentation of VBAC, counseling and informed consent, recording successful and failed VBAC rate, reporting maternal and neonatal morbidity, documentation of continuous CTG, and senior involvement during induction. These are common audit indicators and viva questions. And successful VBAC depends on appropriate patient selection, informed counseling, continuous intrapartum monitoring, and immediate access to emergency cesarean section. So everyone, that's the end of today's lecture on VBAC. Today we covered who is suitable for VBAC, success rate, predictor, antenatal counseling, labor management, induction augmentation, uterine ruptures, warning sign, specific situations like twins, macrosomia, post-red maternal age, and preterm VBAC. The most important message to remember is that successful VBAC offers the lowest maternal morbidity, but careful patient selection, evidence-based counseling, and continuous intrapartum monitoring is essential, and theatre facility should be very helpful. In tomorrow's lecture, we'll discuss high-yield single best answer questions on VBAC, and we'll solve exam-style MCQs together, discuss the reasoning behind each option, and cover the important traps that frequently appear in exams. If you found this lecture helpful, please like, share, and subscribe to OBG with Sadia Dries, and share with your colleagues and postgraduate trainees so most doctors can benefit from evidence-based learning. And thank you so much for watching. Until next time, keep learning, keep growing, and stay evidence-based. Allah Hafiz.